Welcome back. I'm Angelo Snopley. I'm one of the co-chairs of PTAC. We have invited 4 guest experts with unique perspectives to share on developing a balanced portfolio of performance measures for TCOC models. You can find their full biographies and slides posted on the ASPE PTAC website, along with other materials for today's meetings. I will now turn it over to committee member Jen Weiler to introduce our presenters and facilitate this listening session.
Thank you, Angelo. At this time, I am excited to welcome 4 guest experts for our listening session who will present on developing a balanced portfolio of performance measures for TCOC models. At this time, I ask our presenters to go ahead and turn on video if you haven't already. After all 4 experts have presented, our committee members will have plenty of time to ask questions. The full biographies of our presenters, along with other materials for today's meeting, can be found on the ASPE PTAC website. So I'll briefly introduce our guests. Presenting first, we have Ms. Lisa Schilling, the Chief Quality and Integration Officer of Contra Costa Health. Lisa, please go ahead.
Good morning. First, I want to thank you for the invitation to present today. It's an honor to be able to speak with this committee. If we go to the next slide. First, I just want to acknowledge that I am currently Contra Costa Health's Chief Quality Officer as one of my clients, and I will be speaking to their experience in healthcare today. Next slide. My perspective comes from being an executive in quality and population health in several healthcare organizations in the United States. I've either been an executive in these organizations or on the board. So I want to speak to a little bit about infrastructure, how these organizations learn, and then their ability to measure the outcomes that they're trying to achieve. On the left side, these organizations are really structured to focus on clinical acuity and have sophisticated ways to evaluate population outcomes, the care trajectory, and episode treatments. On the right side, these are safety net systems, federally qualified health centers, and they are structured more to focus on the social acuity with the clinical interventions. And perhaps one of the more interesting ones in this group is Contra Costa Health, because they have much of the infrastructure that you see to the left side, but they have accountabilities and structures that support the social acuity on the right side. So I'm going to speak to a little bit about the characteristics of the measures, some organizational infrastructure needed to succeed with total cost of care incentives, and then perhaps some opportunities for incentives to get more providers to participate in these programs. The next slide, please. First, I want to speak to the way we measure inside healthcare organizations and how these programs can incentivize the use of these methods to improve performance over time. First, this is no surprise to any of you, but we really do need to measure what matters and reduce the overall numbers. Even 100 measures is a lot of effort to put into measuring, evaluating, and performing, and it takes away from the resources that can go into clinical care. I also know that sometimes we say we're using the same measures, for example, as CMS core measures, but then when the incentive programs come out, they say, oh no, I want to focus on this population, which requires the doubling of efforts and resources to be able to gather and evaluate that performance. So it becomes more burdensome when we don't use the same operational definitions. To perform over time, it really is establishing improvement targets for year-over-year performance. So if I'm 50% of the way on the trajectory of performance outcomes that I'm trying to achieve, then I need to go 25% better than one year and then the next year to achieve my goal over 3 years. But they also need real-time data reporting. And we know that a lot of the programs at CMS level have older data for good reason. But how do these organizations have data real time to know, is that patient getting the care they need today, or are we performing year over year, month over month in the direction we want to perform? So that's going to take infrastructure. The next slide will talk about certain measures that are already existing. I'm simple about this. Safe, timely, equitable, effective, efficient, and patient-centered measures matter. They're already out there in the space that providers use. Perhaps some of the ones that are most interesting to me are things like misuse. If I have an ambulatory sensitive condition, can I understand whether that patient is using the ED or getting admitted to the hospital? Also, we do need episode of care data, right? We need to understand, are we improving the journey of care for patients who have either high value conditions or high volume conditions, right? Are we improving the journey and the outcomes for the patient? One thing I wanted to mention is that there are a couple of measures that aren't here that are really important, and they're under development. The first is in patient safety for ambulatory care. There are structural measures available for diagnostic reliability. I believe that we need to understand when a person has a symptom, that we have the right diagnostic testing, and then we give them the right care very early on. And we really don't have good measures of that over time for our patient population. So that's one to watch. The other is around patient-reported experience. There is a new set of measures. Sorry, if we go forward one. There's a new set of measures being tested right now around the Community Trust Index. I find it interesting because that measures patient trust in healthcare. I like it because it hits on 3 different types of measures. One is about the experience of care. If I trust my provider, then I'm having a good experience. The second is quality and safety. If I feel like I'm getting quality care, I'm going to trust my provider. And the third is equity. If I trust my provider, I feel like I'm getting equitable care. So I'm watching that set of measures because that's a very interesting development, and I think we should embrace that. The next slide will talk about provider versus group level measures. So we all know this, right? If an individual provider is in an incentive program, they want to know, what am I doing today that's impacting the outcomes for the patient? They don't want to be responsible for the social supports or even transportation to the clinic because they don't feel like they can manage that. So process measures and intermediate outcome measures and care experience measures are what they value the most. I do believe the high performers and the low performers for outliers in populations also can be either positively incentivized or penalized for their performance. It really does take, though, the group and system to be able to have episodic care and population-based risk-adjusted outcomes. And that's why there needs to be infrastructure so that we can see how we learn. I've heard other presenters today talk about getting specialists involved. If you have a group or you have a larger system, they're going to have specialists as part of the system, and therefore we can monitor and manage the population outcomes. So the next slide is going to talk a little bit about what does it take then to be able to work at a group level. I call this the Goldilocks equation. So not so big that you lose the essence of the frontline care provider, and not so small that you don't have the ability to manage in the way we're talking about. So the least structure necessary to maintain what I call a clinical operating system is what's needed. The first 4 things on this slide I think are absolutely necessary to perform against these type of incentive programs. One is a large enough population cohort so that we can learn together. That's why I believe Contra Costa is a very interesting case, because they have 300 to 350,000 people that they're managing with the insurance plan, with the delivery system in the hospital, and then the social supports. It's enough of a cohort to learn, but it's also enough to know at the front line of care every day, you know what you're doing. Some way to have enterprise data, both clinical data and operational data, so we understand what are we doing in care and what is it costing, and can we risk stratify the population to learn more? These organizations that I've mentioned before have a very strong ability to do this. Of course, financial data and cost accounting if it's available. And then finally, how do they structure safety and learning systems to adopt these evidence-based practices? The last slide is really a little bit about my thoughts around what kind of incentives might help individual providers or small groups participate and then become part of a network, if you will. The first is structural incentives. They're out there. They're very helpful if you want to, over time, group into populations and provide supporting infrastructure. These could be incentives for public organizations like state health departments or private organizations to become these cohorts of populations and help the providers learn, as we've talked about. The second is to get those individual providers involved. Pay for performance is a really popular way for them to engage because it seems very simple and very much upside, and state-based initiatives do this already. And finally, maybe one step towards total cost of care measures would be looking at some of the things that are underway right now. For example, I've outlined what California is doing with some of their APM models. The idea of reducing reliance on RVU-based payment, fee for service, and moving more towards per member per month payment. So What they're testing now is a base encounter payment from the health plan and then upfront per member per month wrap. And thinking about the gate and the ladder approach, which is, hey, if you've done what you've needed to do to manage the population, you can continue to get those per member per month payments. But over time, we're going to reduce the RVU burden. We're going to reduce the fee for service and move more into the per member per month payment system. So I think these type of considerations are essential for providers and groups to participate in the total cost of care program. And I appreciate the time that you've given me today to speak with you. Thank you.
Lisa, thank you so much. We are saving all questions from the committee until the end of the presentations, but I know there'll be a number of questions. Thank you. Next, we're excited to welcome back Dr. Robert Phillips here with us today in person. Bob is the Executive Director of the Center of Professionalism and Value in Healthcare. Welcome, Bob. Please go ahead.
Dr. Weiler, thank you for the introduction. In addition to being the Executive Director of the Center, I'm also the Director of the country's largest qualified clinical data registry for primary care, where we do a lot of our measure development and testing work. And I'm also a practicing family physician and work about 12 miles west of here and have been in the same practice for the last 22 years. So the work we're doing in this space applies very much, or I wish it would apply more, to where I'm taking care of patients. I can advance. Barbara Starfield, a number of years ago, in talking about primary care, came up with a set of functions and measures of primary care that, if delivered well, produced great outcomes. They had to do with first contact. Usually we talk about that these days as access. But she also talked about continuity and comprehensiveness, and as we heard last hour, about care coordination. So we've developed measures or adopted measures around continuity and comprehensiveness, and I'll talk about continuity specifically in a moment, but we've also developed some of the patient-reported outcome measures like the person-centered primary care measure, actually developed by the Larry Green Center, but in working with us to test those in our registry and to turn them into a now CMS-endorsed measure. And I was interested in the last speaker, Ms. Schilling, about trust, because we've adopted the Wakefield Trust measure, which was validated more than 30 years ago, and are testing it in our registry now as well. We think these fit the criteria, the rubric that came from crossing the quality chasm that Ms. Schilling mentioned, but we also want to point to the NASM report for primary care that came out in 2021 that said that measures for primary care should be meaningfully parsimonious, they should be fit for purpose, they should be aligned to the internal and the external motivations of the actors, and they should support primary care value functions. And there's a whole chapter in that report about measures and their alignment with total cost of care that might be useful to the committee. Next, please. Well, actually, I'm advancing. So continuity has been used in the US for decades and in many other countries as well. And we actually published a bibliography of all the studies done about continuity, showing that it is associated with lower total costs, with lower hospitalizations, emergency department visits, overuse of healthcare generally, and also with reductions in mortality. It's significantly more highly associated with cancer screening, childhood health screenings, vaccinations, medication adherence, early disease diagnosis, and both patient and physician satisfaction. So it has many of the things you would hope that we would include in total cost of care. And it may be, as some surmised, maybe one of the explanations why other countries have better health outcomes than we do. I'm interested in noting that the proposed rule that came out in July for physician payment from CMS mentioned continuity 54 times. It mentioned longitudinality, which is continuity over time, 36 times, and it mentioned relationships 104 times. But continuity is not a measure used as an outcome or as an evaluation, even though it is a requirement that people taking on the APCM commit to continuity. The Norwegians have some of the best studies around mortality and other outcomes. So here we're looking at emergency services, hospital admissions, and mortality. The blue bar is continuity over 1 year. The green bar is continuity over 15 years or more. and showing that there's a dose effect. There's a reduction in all three of them, with mortality being reduced by 25% for people who have a relationship with a primary care clinician for at least 15 years. So longitudinality really matters. Now I'm getting to some of the questions that you all gave us, less about measures and more about adjustment. So we have focused a lot over the last 10 years on how to increase resources to practices caring for the underserved. And one of the ways that we have talked about doing that is using small area deprivation indices, using neighborhood level metrics as a proxy for the individual. Two of these we've tested now with the U.S. Census Bureau. We've gone into the Federal Statistical Research Data Centers and linked patient data with IRS, with census data, and demonstrated that 8 of the 8 deprivation indices in common use, 2 of them have the lowest ecologic fallacy risk. The neighborhood is very, very highly correlated with the individual. So we're getting closer to saying, you know, if you're going to choose one, which one should you choose? In the series of workshops that we did, one of the questions that kept recurring is, how much do you need to adjust payments in order to meet the social needs that you find in clinical practice? And with Sanjay Basu and others across the country, we found that it takes about $60 per member per month for the average practice. It ranges between $60 and $93. For FQHCs, it's about $115. But look, that is if you get everyone who's eligible for SNAP on SNAP and everyone eligible for HUD support into those programs. So it's in addition to the social services that are already available and eligible there. So my question is, if you're going to start to do this, as CMMI has done across 8 of its programs, are you going to give on one side, on the payment side, and then take away on the quality side? It seems a little unfair to do that. So we've actually proposed, and others have agreed, that it would be helpful to adjust payments and also potentially to adjust the quality scores so that you're comparing apples to apples, not hiding poor care for poor people, but understanding where your quality is based on the risks of the population you're serving. And so you can start to understand, are you doing better than expected, and are you demonstrating improvement over time? In our series of workshops, which had a lot of stakeholders in them, we came to this strong conclusion: you do need more resource into practices taking care of underserved patients, that it should be adjusted sufficiently to address the social needs that you find, otherwise you have underfunded mandates. That you need to make sure, as I think in the last hour we heard a few times, that the resources actually reach the clinic and the patients they're designed to reach, not just sit up in the health system. And that your policy targets should be about improving health outcomes and equity, not just overall savings. At the same time, we said, you know, you should need to reduce burden. Basing payments on the data you collect about the patients you're seeing 18 to 24 months in the future, as was said earlier, is too long, and it creates a real burden for clinicians to collect those data. There's also a lot of incentive for gaming if you're trying to capture those data from the patients, and we've seen that happen with other risk scores. There's the need to titrate the funding to address the social needs, and we think that that's done best in this way because you don't always see the patients who don't come in. And so you're actually getting resources to take care of that population and can move care to them. And then it does create the ability to create accountability for addressing social needs. Are the resources you're getting for your total population actually reaching the patient and making a difference? So again, we think the small area deprivation indices, they have no burden. You can attach them to the patient based on their address. We have an increasing reliability around them so that you can lower the risk or the concern about geographic fallacy. You're talking about the whole patient, not just those who come to see you. It's more reliable because we know patient level social needs vary throughout the year, particularly for the folks who have the worst social risks. They lose their housing this month, they get it back 3 months later, and you don't know that because they haven't seen you this entire year. And it does help align our payments with our measures. And what I've called a virtual cycle here, where you adjust the payments, it gives you the incentive and the resources to meet the patient's social risk assessments. you can actually address the social need either in your clinic or moving those funds out into the community-based organizations. And you're improving accountability because you can start to look at, based on the risk of my patient population, am I doing better than expected or doing better than I did last year? Thank you very much.
Bob, thank you so much. Next, we're happy to welcome Dr. Barbara McAneny, who is the Chief Executive Officer of New Mexico Oncology Hematology Consultants and former president to the American Medical Association. Dr. McAneny is also a previous submitter to PTAC with the Mason model, making accountable sustainable oncology networks proposal. Welcome, Barbara. Please go ahead.
Thank you very much for inviting me to do this. I have great respect for what you are trying to do and was an advocate for the Affordable Care Act from the AMA and an early adopter of some of these issues. But I'm going to tell you a bit about some concerns I have, and I hope that you can take these comments in the spirit in which they are intended in terms of doing a better job for the patients we serve. Next slide, please. So I'm concerned about whether or not we are indeed meeting that mission of improving quality, improving health, and lowering costs. And unfortunately, I think the cost changes have been minimal. The quality has been minimally improved, but only on specific things. And one unintended consequence is the increased consolidation. I remind people that as a physician fee schedule practice, if I sold my practice to a hospital and saw the same patient the next day in the same office, in the same exam room, did the same things, under the hospital outpatient, it would cost double. So consolidation is a major driver of cost that has to be considered. Next slide. So we've looked at all of these models, and I'm not listing all of them, I'm just listing some selected ones, because I think they were very well intended, but I don't think that they have achieved the goal of improving care and saving money at the same time. And I will remind people that as a physician, my main goal is to improve care. Saving the healthcare system money is a secondary consideration for me as a cancer doctor. My first is to give the patients the treatment they need. Next slide. So in 2012, I received the Come Home Award, $19.8 million. And Come Home was a very successful model. I'll just show you some data in a minute. What it did, it was not a payment model. It was how to do a practice. And so with apologies to pediatrics and primary care, we created the Community Oncology Medical Home, which is what Come Home stands for. And we were able to figure out what patients cared about, which is staying out of the hospital, spending more time in their home with their family, having better health. We worked it by having people we figured out what would be the earliest indicator that a hospitalization was on the way, step back 2 steps, intervene then with an office visit rather than emergency department or hospitalization. And we discovered along the way that not only were patients healthier and happier about it, that we saved a lot of money. This went then into the oncology care model, which added a lot of data collection and added risk. Wanting to put the practices at risk for cost of care, and now it's moved into the enhancing oncology model. I participated in an oncology care model and did very well with that. I declined to participate in enhancing oncology model because of the way the data was collected. I take care of a lot of Native American population with my clinic in Gallup, and I asked my patients what they thought about my submitting their data to Medicare, who they see as the government. And I would have lost the 17 years of trust that I have built and giving cancer care on the reservation had I submitted all that data. So I elected not to go into EOM. Next slide. So Come Home, it did use IT systems. We did do a lot of data provision, but it also based on that ongoing relationship with the cancer doctor, and it was physician-led, team-based care with financial counselors, navigation done not as nurses to navigate, because frankly, that's too expensive. My nurses are sitting on the triage pathways, getting patients in when they need to be seen, not when it's convenient for me to see them. And we still do 15 to 20 same-day visits every day, which results in having a hospitalization rate that all the way through the oncology care model was about 2/3 of the OCM average. So we still do that. I still think that the best way to prevent a readmission is to prevent an admission. And we did a lot of patient education with that. The other thing that was part of Come Home with my practice and the 6 others that participated is that we provided them funds to build the infrastructure of triage pathways, nurses doing triage on the telephone, people navigating as appointment secretaries, et cetera, helping with the financial costs of having cancer. And we were able to do this because we offered a very nice carrot to all of the practices in terms of payment for doing these things and in terms of giving them the resources. Come Home worked because we made it easy to do the right thing and we gave people tools to do the right thing. Next slide. So this is one high level from NORC that shows what we managed to save on average, overall $673 per patient, which is actually better than most of the other models that have been in CMMI. However, you'll notice that this was not a model intended to save money, and there was no risk in this model. We just did what we did it better, we took care of patients better, and that is what saved money. And to me, that was the huge part. And we also found that we could save a lot of money at the end of life because we had built that trust that the previous 2 speakers have talked about as well. Next slide. So ACOs, I had great hopes for ACOs when they started and watched a lot of them, but I have some concerns about what has evolved with ACOs. Next slide. We were hoping that ACOs would be able to improve primary care access because as a cancer doctor, I'm not very good at managing people's diabetes and hypertension. It's not what I do. But I find there's very few primary care doctors out there for me to partner with in taking care of these patients. And the alarming statistics coming out of the AMA worry me considerably with the burnout rate being so high and the number of residents in primary care who are in practice as opposed to being hospitalists or doing other things. Next slide. So my take on ACOs, and actually on most of the CMMI projects we've done, is that there are minimal savings there. It did teach these systems, particularly the ones that had a hospital involved, how to cherry pick and find what I call the Winnebago seniors and avoid cancer patients and other sick people. In my attempts to work with ACOs, cancer was always carved out. So as soon as someone got sick enough to need specialty care, they were out of the model. And so what that meant was that the success of the model was really based on patient selection and not on better management of sick people. And we went to school to take care of sick people. The inadequate rewards for physicians. I had a primary care physician in my network talk about their dissatisfaction with trying to work in value-based care models because the value tends to go to the payer, and for the doctors, it's a race to the bottom. We can't have that because we'll lose the infrastructure of care. And it focused so much on population health that when somebody said, I'm sick today, will you see me today? There was no process in place to manage that. And I've already spoken to the consolidation, which is, I think, the worst thing that ACOs have contributed to. And I think that's a significant problem. And it also morphed in what I fondly call Medicare disadvantage. And you all know what Congress is looking at in terms of the increased payments to these programs. I call them disadvantaged because I find that cancer patients who sign on with one can't participate in clinical trials. When they need to have any Part B drugs or anything like that, they discover they can't afford them on this plan. And there's a lot less money delivered to be able to deliver these services. So I'm exceedingly disappointed and have great hopes that you at PTAC will advise CMMI to take a second look. Next slide. So we've focused so much on risk and on putting physicians at risk, and I think that is a mistake. So as we've developed all these models, we've switched to carrots that are shrinking every year and sticks that are getting bigger and bigger. And unfortunately, physicians do not respond well to sticks, but they do respond well to being given a carrot and being given the tools that they need to do what they're supposed to be doing, which is delivering quality care. So if I got to do quality measures, and we do quality measures, we do well on them. I call it documenting for dollars, because none of the quality measures I do for MIPS make any difference in how I manage patients. I would look at the days from the first phone call to when I get them in, when I have an appointment. That tells me access. That's what patients care about. The days from the first visit to when they are on treatment, because that's the other thing cancer patients care about. And that also gives you an idea of the efficiency of my doing the staging workup, getting the port in, all of those things. I want to know that people are doing same-day visits. Treat the patient when they wish to be treated. And that is what cuts down an emergency department visit. And that you have, is your team working at the top of your license? Our mid-level practitioners, nurse practitioners, and PAs are not determining oncology treatment plans, but they are seeing the same-day visits. And then you can look at the hospitalization and usage. However, if CMS really wanted to save money, they would look strongly at the site of service, because that is the biggest variation. And even this year, with a 2.9% cut to the physician fee schedule and a 2.6% increase to the hospital outpatient prospective payment system, we are just widening that gap, and that needs to be addressed. For outcomes, what I really put quality measures into two buckets. One is the clinical quality, the technical quality. Do I know what I'm doing? Am I treating the patient with the right drug or the right treatment? And to me, the easy answer with that is pathways. We're working with the Dana-Farber pathways. I think that we should direct academic institutions to create pathways for more than just oncology so that we can use those. I put that in Mason. Robert Carlson, who was the head of NCCN at that time, suggested 80% is the right answer. Not everybody is going to be compliant, but you need to have a thoughtful reason why you're not on pathway. And then we need to look at risk assessment. As the other speakers have said, it takes more money for me to manage patients who have fewer resources of their own. Yet our current system penalizes people who are in rural areas or poor areas by basing the gypsy adjusted payment to apartment rent and non-farm labor, and that does not account for the social determinants. And with the other part of quality is the customer service part. It's the access, it's patient satisfaction. Next slide, please. So here is my message to CMMI and to PTAC as the conduit to CMMI. We need to rethink about putting practices at risk. It hasn't worked. We've been doing this now for the last 12 years, and we are not going in the direction we want to go. So if you've been doing something that long and it isn't working, maybe it's time to think about other things. Do we really want to put practices at risk of going out of business? Do we really want them consolidated into hospital-based systems? The other thing that happened in OCM to a great degree was that I would find that if I chose what I thought was the best drug for the patient, it would be the worst drug for the practice. So let me talk a bit about drugs as the total cost of care issue that is most affected by oncologists. So the way we are paid, for example, to infuse a drug, that fee schedule has not changed since 2005. Since that period of time, we've added little expense items like EMRs, USP 800 compliant pharmacies, pharmacists, oncology trained nurses, et cetera, yet the payment has not changed. And we make up for that on the drug margin. And I will freely admit, and I don't like it a bit, that we run our practices based on the drug margin. And that drives CMS crazy, frankly, because they're afraid that I'm choosing drugs based on that. I will tell you that if there are a drug that does a better outcome for a patient, we're going to choose that. And Pathways will let us know about that. But if in the case, for example, of biosimilars, where there are two drugs that are absolutely equivalent, I'm going to choose the one that puts more money in the practice, because I have to pay for the shortfall of Medicaid and Medicare patients. I have to take care of the infusion. I have to do the social workers and everything else, and there's no money for that. So am I going to put my making payroll next week over the nebulous idea that in 6 months I'll get some payment that may or may not help me with that? I'm picking the payroll. And if there is the concern of, am I cutting down healthcare costs for the system, or am I making payroll and keeping my practice alive and able to take care of patients? You know which one I'm picking. I'm picking the practice. So if you want us to not base our financial well-being on the drug margin and get the drugs out of total cost of care, I think you ought to look again at the Mason project, because we took that money out of drugs and we put it into infusion, into the doctor time to be able to explain the treatment plan to a patient, into all the support systems, et cetera, that is necessary to do a good job taking a cancer patient, and pulled it out of the drug margin. But we can't just put the drug margin to zero and expect the practices to somehow magically find money to cover all the things that the drug margin was taking care of. The surgical fees, as we add surgeons to the practice, this is a problem. I cannot afford to hire a surgeon to try to keep them in New Mexico, because 85% of the payment for the operation goes to the hospital and not to the surgeon. And my advice to CMMI would be, one size is not going to fit all. What works in oncology may not work in primary care, may not work in psych, may not work in OB. We need to do 1,000 pilot projects and then figure out which ones work, because there are a lot of doctors out there who have really good ideas about where there is waste and what would do a better job. And the other thing is, I do not believe, you can go to the next slide, that we are going to be able to save money in healthcare until we actually know what it costs to deliver care. Cancer is getting increasingly granular, but the lumping together of all of these patients into one bucket that is an at-risk bucket is completely opposed to the idea that care is very, very granular. When I wrote the Mason project, Making Accountable Sustainable Oncology Networks, we found that in the come home data, we could find clusters of payment, and then we could figure out why was this patient more expensive than that, and was it something that the physician could control, or was it something that was patient related? Total cost of care should be minimized to going into total cost of cancer care for a cancer program. If my patient gets hit by a bus on the way to the clinic and they end up in the ICU for 2 months, I would be accused of delivering lousy cancer care because my total cost of care would be very, very high. To me, that makes absolutely no sense. And so I think in this day of data sciences, we should be able to take the massive amount of claims data that Medicare has, work with groups of practices who are interested in doing this, and be able to say, okay, why is this patient more expensive than that other one? We found, for example, that patients who had stage 4 pancreatic cancer, if they had peritoneal mets, they cost the system 4 times as much as those who just had metastasis to their liver. But there was nothing I could do about who's going to get their metastasis to the liver only or the peritoneum. So if I got more patients with peritoneal disease, I flunk and I'm a bad doctor. If I got all my patients with liver only, I'm a genius and I make extra money. That is not the right way to do this. We really need to use data science to really determine what is the optimal cost of optimal pathway-driven care so that we know what we're paying for. And then we can look at how much money are we spending that's over and above what we should be paying in healthcare. And I think that I would switch the gypsies around 180 degrees, and I would pay more for the rural patients, the disadvantaged patients, the people who have no resources to take care of themselves because the practice or the system is getting increased expense to try to get the same outcomes on that. I think that's my last slide, but thank you very much for listening to me. And I hope that we reconsider this.
Barbara, thank you so much. And I am sure there'll be lots of questions on your presentation. Thank you. Next, we have Dr. Sarah Hudson Scholle, who is a principal with Levitt Partners and here with us in person. Welcome, Sarah.
Thank you so much. I really appreciate the opportunity to talk with you today and to introduce to you the Alliance for Person-Centered Care, which is a multi-stakeholder group that has come together to address and facilitate the collection and use of patient-reported data in clinical care and in quality programs. And the Alliance formed because it believes that person-centered care should be the benchmark for quality and that effective use of the patient-reported data can enable person-centered care. So why the focus on patient-reported data? And all of our members are coming from having experience either as people with lived experience or people working in different healthcare settings who are interested in how we put at the forefront of our healthcare system what matters most to each individual patient. And we know from the research that there are many benefits from having this conversation, from understanding what matters to people. It shows up in better shared decision-making that allows for care plans that address what the patient's goals are rather than what healthcare has to offer exclusively. It helps people understand their condition, to have expectations about their care, to be involved in monitoring and supporting their own recovery. It can facilitate communication. We have patient partners that are members of the Alliance, and one of our patient partners said, this is the way that we have a common language, that we understand what we're doing together. And we know that you can enhance treatment and reduce disparities as well, because by focusing on what matters and focusing on patient-reported data and these outcomes, we can identify where there are variations and we can focus efforts to reduce those gaps in that way. So how do we actually make patient-reported data, patient-reported outcomes part of our set of measures that we use and work on them day by day? Well, it depends on having an entire system to support the use of this information. And that's a big change in how healthcare is provided today. It means that patients need to feel empowered. In our research that I did when I was at the National Committee for Quality Assurance, I had people say, I've never been asked what's important to me. I've never been asked what my goals are. So we're actually asking people to serve in a different role in relation to their healthcare team. Clinical teams need to be bought in. That means they need to know what to do with the data and have the support to do it. They need tools that make it easy and equitable to collect and use data over time. Policy needs to support this, and the investments need to show value. And so our alliance is really about taking this belief system and then saying, here's how we put it into practice, because we know some places are doing it, but it's really hard. So these are the members of the Alliance for Person-Centered Care. And as you can see, it represents a whole array of perspectives, including people with lived experience and different kinds of providers and systems. I did want to define terms because I was asked to speak about patient-reported outcomes today. And so a patient-reported outcome is what we're measuring. It's the question, it's the concept we're trying to get at, whether it's functioning or depression symptoms or trust. There's a tool that we use to measure that. It could be the PHQ. It could be a promise tool. It could be one of those trust instruments that my colleagues have mentioned. And then there's the performance measure. That's how we determine whether there's improvement or an average performance. And so I think as I've been working on this for the past few decades, I know that these terms are unfamiliar to many in clinical care and they get confused. In our alliance, we think about we use the term patient-reported data because actually it's not an outcome until you've constructed the outcome measure. But we do think that there are a number of topics that patients can report on that are relevant to their clinical care. And some of those are listed here, from goals, well-being, relationships, preferences, health-related social needs. These are all things where the individual, whether it's the patient, sometimes a family or proxy, who is talking about what they believe, what their experience is, without interpretation of a response by a clinician or someone else. So the Alliance formed because we realized that there are a number of issues that get in the way of patient-reported data being used today. And we're working on deliverables that relate to policy, data and infrastructure, and implementation. And our first deliverable is really about what are the principles that should govern the use of patient-reported data. And we actually developed these principles this year and used them to develop a comment letter that was submitted to CMS in response to questions in the physician fee schedule. And just to summarize our key points, which I'll walk you through, it's about starting with what matters to patients, rebalancing the set of measures that we have so that we focus on value, equity, and innovation, and really reduce the burden on clinical organizations today, the burden of quality measurement, and then investing in sustainable implementation and improvement. And so let me walk through and explain how we got to these principles and what's coming forward. So there's ample research, and especially if we look in academic settings, if we look to other countries, we see that the use of patient-reported data and these performance measures that are based on the data can be impactful. But it really requires changes in how care is delivered. It changes workflow, it changes the culture, it changes the relationship of a conversation. If you're asking patients about their goals, and that means, wait, it's not really consistent with the care plan I would typically use. So actually doing this it's not easy. And one of the things that our alliance really believes is that the way to determine what are the right measures that should be in a set of measures for this type of model is to start by asking patients and families who are in that target population, what are the measures that matter? How should you collect the data? How can we make this more feasible for the entire system? Because often patients and families have simpler solutions than a healthcare team that might be at fault, thinking that they need to have a research project where to do it. But we've found that actually having relevant and actionable data for the particular condition or the particular population is important. And you've heard today from my colleagues about how that might differ depending on the group. So with Barbara talking about in oncology, what's important there, and Bob talking about trust and others in those settings. So what does it mean to rebalance measures? Well, the measures that are used in these programs need to generate data and insight that will affect outcomes. And so we're looking at outcomes that really make a difference and that clinicians and patients believe is important to work on. That means that you really have to remove the measures that bring less information and value. Now, one of the key issues that shows up here is, well, does that mean that every group has a different set of measures and that we have to have only specific measures? We don't think that's true. We think there are generic measures that could be used often across different populations that allow for comparison and support. But there are some cases where specific measures are needed. For example, for people with intellectual and developmental disabilities, we don't have measures that have really addressed the concerns of that population. That's why it's important to have patients and families from each group to say, yes, will this work? Or is there something new we need? Of course, these should be considering disparities. This means that we have to make way for new types of measures. And so we see within our alliance, a number of groups are working on new measures that can be added to programs instead of saying, we've got a set and we're just going to choose from the ones we have. I think one of the biggest challenges that we've heard and that I've experienced when I was at NCQA, I helped to develop a set of measures around depression, remission, and response. And I was really excited. I thought, this is great. We've actually turned, for mental health, we've moved away from just measuring visits to looking at whether people are getting better. But those measures have not taken off. They're really hard to implement. They're hard to implement because it means that you have to collect information over time, and many places don't have a way to do that in a seamless way for patients that don't come back. It's hard because clinicians might not know what to do if people aren't getting better, which is the whole point of measuring, is to see what do you do. It's hard because it's hard to understand who within your panel of patients is getting better. Which of your doctors or therapists are doing a good job? Where should we focus our attention? What other services should we offer besides medication? Where do we get the therapy? How do we address the social needs? So actually pulling in measures like this require an entire workflow. And I think back to one of the speakers from the previous session who talked about, you have to think about everyone along the pathway who's involved in using this information and what is their response? How do they know what to do with it? How do you even talk with individuals about why you're asking the questions and where are the data coming? And do people who are reporting on these important things that they believe or experience, do they get that information back? Hey, you know what? I notice your symptoms aren't getting better. What's going on? How can we do something about it? So all of that structure needs to be in place. Otherwise, it's just a measurement for measurement's sake. It's not actually helping patients. And what I've heard from the members of the Alliance and from others, there are cases where patient-reported outcome measures are being dropped into models or dropped into payment models, and they become just, can we get the data, not how is this really changing care? And so that's where our alliance is really looking at, and I'm going to go back a couple of slides just to say, as we think about adding patient-reported measures into care, we think it's going to make a big change. We need to start with what matters to patients. We need to rebalance the set of measures so that we account for all the work that's going to be required for these measures, but also removing measures that the potential value and equity that you can address with these patient-reported data, and then invest in the implementation that's going to help us improve and actually meet our goals on reducing cost and improving population health.
Wonderful, Sarah. Thank you so much. At this time, I'm looking to my co-panelists. I know you have a number of questions, so please tilt your tent cards, and we'll start first with Ginny.
This is directed to Sarah, but I would love to hear all of the panelists opine on it. So one of the concerns we have as we kind of take a step back to measures is attribution. So for example, Sarah, patient-reported measures are only as good as who they recognize as their physician, right, and group. And so how do you see us balancing patient choice with being able to get attribution to a point where these measures are actually relevant?
So I think that's the issue here. And, if you think about where are the data collected, how are the data used? And if these data are collected and available in the clinical setting, which is part of our the Alliance's goal, right, is that it's not the attribution issue actually shows up because you're being asked this question because your clinical team member says, look, we would like to know about how your symptoms are evolving over time, or we would like to understand what your goals are. And that becomes part of the clinical care plan. So so this is not a model where you take a sample, you do a survey, and then the information gets attributed after the fact. It's really part of care. Now, the issue there is how do you get sufficient sample size to get to get to being able to have enough data to know whether what performance should be, and whether people are meeting benchmarks. So there is kind of a push-pull there on how you understand it, how you collect the data, and the quality of the data, I think.
I think it depends on the PRO-PM, on the patient-reported outcome performance measure. If it's about value, that is about the patient, and the attribution is less of a concern. If it's like the person-centered primary care measure, where it's about the relationship and different aspects of the relationship, then it matters a lot. So if you're in a health system like I visited last week in Texas, where a driving metric for primary care is number of new patients seen per month, which shreds continuity and relationship, then PC-PCM is probably not a great measure for a clinician through attribution. It might become a more powerful measure for the system that, across your patient population, your patients are not rating their relationships or feeling like their needs are being met, or that they've been through a lot with their PCP. So for me, in a system that does not have attribution baked into the model, then it really becomes a measure of how are the patients rating the systems meeting their needs.
Angelo.
Thank you, Jen. So my question is for Barbara. Obviously, anybody else can chip in also. So Barbara, I very much appreciated your presentation. Great comments and very direct and clear as usual. And what I wanted to get your thoughts about was the things that you mentioned obviously made a lot of sense. As we talk to other specialists, particularly the non-procedural specialists, the more cognitive specialists, their request is how can I be more integrated into the ACOs as opposed to being separated, because we haven't really figured out a way to separate those non-procedural specialists out into a separate model. Have you given any thought to their roles and how they should think about participating in ACO, and any ways that we can advance engaging those type of specialists?
I think that, thank you for the question. It's a great question. I think it harkens back a bit to attribution. When I am seeing a cancer patient, I basically am doing their primary care. I may yell for help when I mess up their diabetes to their primary care doctor, but mostly they're in my office constantly. So attribution really needs to follow who is managing the intended disease that is really foremost in the patient's mind at that point. To be able to put other specialties into an ACO, I think requires a model redesign. And I'm actually working on one here locally in Albuquerque, a clinically integrated network, which we are designing to put the attribution for the quality measures and the PMPM management of various things with the appropriate specialist who's doing it, with the primary care doctor as sort of the umpire to make sure that things are all going properly. But our goal is to create a clinically integrated network where we are paid well for managing the very expensive chronic diseases that we manage. And I think the model we used in Come Home, where we take chronic disease, which I include cancer in now, and you figure out when that person is going to have an acute exacerbation, which is where the expense comes in. Then you have an opportunity to intervene early and prevent the hospitalization, et cetera. So for example, COPD, about $55 billion a year is spent on COPD, and most of it happens when the patient decompensates and ends up in the emergency department and the hospital. So if we used the come home process of early intervention and office visits, which are a low cost thing, then we ought to be able to impact that. I see that the same thing happening with diabetes, with renal failure, with congestive heart failure. I think we have to redirect our quality measures and our interventions toward the exacerbations of chronic disease. There will always, however, be acute illnesses that just need to be managed at the time when they're managed. So I wouldn't throw fee-for-service baby out with the bathwater, because when we had lots and lots of doctors, they had the time to maybe churn and see people more often. These days, we have a shortage. We don't have time to see people who don't need to be seen. So if somebody has an acute stroke, or they've discovered they have a relapse in cancer and they need to be seen today, the main way we're going to encourage physicians to do that extra work is to pay them perhaps a differential for putting that patient in on an acute visit, or building a system that allows us to manage that. Did that answer your question?
Yes, thank you.
Lee.
This is directed at Bob primarily, but I think others will have thoughts and opinions about it. And I want to dive a little bit more into ADI, a topic I know I've talked about and shared, and I'm fascinated by its potential role moving forward. And can you just expound a little bit more about how you think about ADI, and what are all the various places it could have an input, which conversely to what are the best places it should be used as an input? For instance, I mean, as a risk of, as a marker of social needs or resources, I mean, it would have both inputs to make fee-for-service work better under the basic principles of RVRVS, and in value-based care as well. So, I mean, it could be a risk adjustment, it could be an input to a risk adjustment system. It could be tied to payment directly, right? It could be a modifier. It could set baseline goals. It could be used to adjust quality measures. Where would you start and best focus?
Well, I think the first place is where CMMI has started, and that is with payment adjustment. They've done that as a global payment usually, and Maryland did it as a heart payment. So heart payments are a combination of clinical risk and social risk. And based on that, using the area deprivation index, they get paid up to $110 per member per month for someone who meets that threshold risk score with that combination. I think that puts money in the hand of the practice. You know, they get a quarterly check, $500,000 with some loose but important guidance about how they use that. Are you hiring community health workers? Are you hiring social workers? Are you doing food vouchers? I mean, very direct kind of service provision that you can't typically fund out of fee-for-service when it's tied to visits, because now you're focused on a population of patients that you have, and particularly addressing those who aren't coming in. How do we get the community health worker out to them? So I think payment is a really important thing. I think it is really important for population health assessment. So in our register, we've actually built a capacity to use patient addresses to tell you the service area that you're taking care of. In my practice, we found that physicians overestimate that geography by 100% or 160 square miles. So it helps you focus and get very specific about who am I caring for, and then what are the risks, the social risks of those populations that I'm caring for? Is this neighborhood comparable to this neighborhood? We had residents who used that tool to map their patients with food insecurity so that they could really locate the 4 neighborhoods where they should put that mobile food delivery, or they should put in a SNAP subsidized farmer's market. So I think the deprivation indices help you get focused on where are the populations that I need to take care of and how do I take care of them where they are. But then I think risk adjustment is another place where it's important. In my practice in the 3rd wealthiest county in the country, we found significant differences in quality for our patients based on the deprivation index. So, you know, geography matters, neighborhood matters. And it's not that we were systematically biased against them, it's that they couldn't fill their medications or they couldn't travel to clinic as often as we wanted them to. So again, I don't want to hide poor care for poor people, but I want to understand, are there differences related to social risks? And then, am I doing as well for that population as I would be expected if I adjust? It doesn't absolve me from fixing the inequities I find, but it tells me how is what I'm doing actually making a difference for that population, even if that inequity is still there. Those are the 3 most important ways I would use it.
Barbara, you have your hand up?
I do. And I come at this from my practice, which has a clinic in Albuquerque and a clinic in Gallup, which is the medical heart of the Navajo Nation, average income $20,000 a year, often no running water, no electricity. Telemedicine is sort of a wasted effort there. And I have a couple points I want to add with this. One is it does cost me more to get clinicians or even patient care coordinators or other people to work in an underserved area than it does to get them to work in Albuquerque, and I pay more. For the last 22 years, we've had a foundation, and I do not think philanthropy is the appropriate underpinning for a healthcare system, but we created it to actually pay patients' bills, because if you're going to be thrown out of your house and get your chemotherapy living in your car, you're probably not going to show up to get your next treatment, and then outcomes are much, much worse. And what I see as people have now discovered the social determinants is that we're busily measuring them. I find it a little heartless to measure something and ask the patient, so do you have food insecurity, without having something to offer them in exchange for that. It seems just heartless to me, and it will destroy trust. So one of the things that we make sure we do is we get the appropriate patients to whomever they could choose to disclose to that they have a problem. And any patient who discloses to any member of my staff that staff person can make a referral to the foundation, and we will help them manage these issues. So it kind of goes back to ask the patients what they need. Sometimes it's firewood, sometimes it's food for the sheep, you know, so we don't limit it on that. And the second point I want to make is to set up the infrastructure to do that. I love the idea of a bulk payment so that I can just do these things without depending on philanthropy. But to set up the infrastructure to be able to manage the social determinants and other things is hugely expensive because it's people who want salaries and need a place to work. And so we really have to look at that cost and make sure we're paying for it. And then as you direct CMMI, one of the things that offended my Navajo patients and therefore irritated me was that when they came up with the enhancing oncology model or even the oncology care model, they did not partner with the Indian Health Service and they did not partner with Medicaid. Where do they think these people are? And a lot of people are buying the Medicare Disadvantage plans because they have a zero copay. That's where poor people are going, and then they discover they can't get the services. I pay people to find free drug so that the Medicare Advantage program who's denied that drug, that patient doesn't die for lack of that. So the place where we are putting our money is often in the wrong area. They need to partner with Medicaid. For the oncology care model, we had to drop a chemotherapy bill to get any of the payments for support. Well, if it's a Medicare, Medicaid dual eligible or Indian Health Service, the oral chemotherapy is paid for by those entities. So I never dropped a bill to Medicare, and therefore I had to pay back all of those MEOS payments that paid for the support I was giving those people, the people who need it the most. So that was, to me, sort of a perverse way to look at this. And so I hope you'll pass that. I did tell CMMI that directly, but I'm hoping that PTAC can reinforce that.
Lisa.
Yeah, I want to carry forward a little bit of what Barbara just said. So earlier we heard from one of the speakers about holding the academics accountable for creating clinical pathways because that's their expertise. I'd like to put that on the other end, which is the safety net systems and the FQHCs and other. I'm in a county system that has all those wraparounds and supports, right? And there are community-based organizations that they're required to participate with. And I understand that I'm in California and there's an extreme unevenness about how the communal systems work, right? How the county systems and state systems work. But that being said, I would love to understand how CMMI might work with HRSA and others to create some networks. Because if Barbara was in my area, my system would be working with her to make sure those social supports and wraparounds actually exist for those patients because we're accountable for them. But we would want to partner with her in order to provide the services that she provides. So how do we, without creating too much infrastructure, because I also agree too big a system is not really great for the patients or the providers. How do we create some networking or cooperation and collaboration between the organizations that have the social assets, the social supports, with those who have the clinical supports?
Great point. Larry, your hand is up next, and then we'll go to Jim.
Well, I think I'm getting redundant in all my comments as I open up a question. I'm just continually impressed with what I'm receiving as a member of this committee from the subject matter experts. And I guess we should give some credit to the PCDT and staff for bringing such a great team of speakers. There has been a theme through a couple of the sessions yesterday, which was brought up again today. And that is that the drivers for business success for a medical practice should coincide with the population health value drivers as well. And those two have not necessarily been in sync. And we talk about something called a physician fee schedule. Well, maybe we need to start thinking about this as a practice business reimbursement schedule. And It begs a question, though, and I know I'm going to fire up Barbara here, but it begs a question because what medical entity does CMS really want to favor? Do they want to favor the small practices? If they do, then they need to change the way they're reimbursing because they're reimbursing large entities, and we're seeing this tremendous consolidation that's occurred since the Affordable Care Act was passed. The other thing that I think came out very strongly here is that a visit is not a visit is not a visit. We heard yesterday that new patient visits require 10 times more work than a return visit, and yet the compensation does not reflect that. What I just heard now was that maybe a TSA pre-check, a clear status to get a patient through the maze of the visits when they really need to be seen needs to be compensated better, because maybe, just maybe, if we compensated the practice more to get that patient in quicker, we'd have less emergency department visits that are resulting. I guess I made statements and not a question, but I have to say that you've really impacted my thinking processes.
Any thoughts or reflections from our?
Barbara, you have to say something.
Yes, I would be happy to say something, and I agree with you. And one of the things that really I wanted to stress was carrots work, sticks don't. Risk is a stick, and a stick that could potentially put me out of business, and then who's going to Gallup to deliver cancer care, right? And so carrots are the way that I think we should move forward, and physicians respond to those well. They respond to sticks with burnout and leaving the practice. And this is not something we can afford, because CMMI and PTAC need to take the physician shortage into account. My concern is that as we keep adding on another nurse to manage the electronic patient-reported outcomes, if we don't develop a system where those things go into our dashboards and we can manage those patients, that we will just have an overburden of expense and of missed messages, which destroy trust. And so what we do in the practice that I consider my laboratory for value-based care processes is we pull all of that data into a dashboard. We're doing telepsych via screening and then hooking people up. One thing that if they want to make a difference on some of that, get rid of the copays for some of these coordination of care codes. You heard earlier from our primary care colleague that coordination of care saves lives. It does, but a copay of $10 to one of my Native American patients is unaffordable, and it costs me more than $10 to collect it. So let's get rid of those kind of things in our CMMI programs. Let's encourage patients to do what we think is the right thing for them to do, encourage the doctors to do what we think is the right thing for them to do, and leave the sticks at home.
So CCM and PCM and TCM should be first dollar claims.
They should be, because I have patients who don't want to do that. And even when I have the depression screening, which we're doing on every patient, when I suggest that they take advantage of our telepsych process, they say there's a copay. Thank you very much. I'll just talk to my sister. And then I have no way to know whether or not talking to your sister is a very effective way to manage your depression.
Great point. And if you don't have a sister, that could be even more challenging.
That's right. Everyone needs a sister.
That's right. Jim.
Thank you very much. It's great listening session. This is for everybody. I was struck by a thread that was almost in everybody's comments, which was trust. And I'm going to flip it for the sake of our conversation to trustworthiness. I think that And I think that it's implicit in what you were saying. I think Lisa even kind of probably got it right the first time when she spoke, which was this trustworthiness of us is really vital, in particular in the county work that she's doing. And I think all of you said the same thing. And projecting onto the patient that they've got the problem of trust troubles me just a little bit, as opposed to the system has the problem of being trustworthy. So I just kind of, that's an editorial. But I really wanted to go deeper here because we have a few more minutes. And this health-related social needs used to be called social determinants of health, and trust was a thing, and it was, our trustworthiness was the thing. It's kind of like, well, different sides of the same coin. But embedded in that trust, it gets sanitized just a little bit, doesn't it? Our trustworthiness, because embedded in there is this notion that some populations experience bias in their interaction. And the bias can be in a lot of different spaces and different moments, and it can also be characterized by a lot of different adjectives. And that puts people on edge, and we really don't want to talk about that because it's really still part of the currency that we need to think through as far as how do we talk about trustworthiness as a health-related social need? Is it an outcome of doing great work in health-related social needs? Is it catalyzed by addressing that? And are there any models or experiences the experts have in taking a look at that trustworthiness scale and connecting it, drawing a through line to improvement in adherence, improvement in particular in value-based models, chronic disease management, prevention therapy, acute management, particularly like this issue around pregnancy-related morbidity and mortality for certain races. It's an acute event often, and there seems to be a pretty significant disparity that keeps persisting. And I wonder if bias and perception of bias and trust and trustworthiness all fit with all of that. So I'll leave that there as y'all talk through this.
Well, at the risk of jumping in too much, I'll jump in too much. You absolutely have to earn trust. And the first part of trust is showing up and showing up consistently and not just going away, not being one intervention. I think our healthcare system has switched to episodic type of care. You go to the ER, you go to the urgent care clinic, you go to your primary and you see their nurse practitioner, you don't see your physician because we don't have enough of them. And it's really hard to build up trust without building that relationship first. And I will point out that's why I declined to participate in the Enhancing Oncology model, because I wasn't going to sacrifice the work I've done for the last 17 years to have someone who looks like me build up trust on the reservation to be able to have those patients disclose to me what they need to for me to be able to have a meaningful partnership. The other thing you have to do is recognize that about 80% of the issues are poverty, but 20% are cultural. When we built our Gallup Cancer Center, we put a classically built hogan in the front yard. That is a ceremonial building as a signal to the community that we were respectful. We work very hard to support the local entities, open our cancer center up. We now have Women's Wednesdays where we have a bunch of elderly Navajo ladies doing crafts and line dancing in the cancer center, which I think is just a phenomenal thing, and it shows that we're succeeding at building trust. But you can build it over many years and you can destroy it in a moment. And so that consistency part that you heard before, that has to be there, and it has to be a value of the practice or the system, and it has to be constantly reinforced by leadership, and deviations from that can't be tolerated. The other thing is that you ask the community what they need, nothing about us without us. And so you reach to the community you're trying to serve and find out what it is they want to have done. And one of the best ways we found to do that is you hire people from the community and you offer them that entry-level job, and then you continue to grow them. And some of our entry-level people have just completed a job being a radiation therapist and are working in our Gallup clinic to help treat patients. And so we've offered career paths, and you have to embed yourself into the community and be there for the long haul.
Lisa.
Yeah, in my experience, trust is about belonging. And I think Barbara touched on this, but what we found both when I was at Kaiser Permanente and in Contra Costa is that you can assign a person to a clinic or a provider, and that person may or may not go there, right? Where they'll go is where they feel welcomed, they feel they belong, and they feel treated culturally and socially in the way that they expect. So in KP, we would assign people to clinics, and we found people would drive more than an hour to go out to a clinic where the providers affiliated the way they did with their care. And likewise, in the safety nets in Contra Costa, the Latinx and Hispanic population tends to be drawn to Contra Costa. And you can establish programs, right, that help with that affiliation. I think Barbara spoke about it, but for example, centering pregnancy, we talk about Black and African-American women who are pregnant, having a centering pregnancy program where women of that community are leading the centering pregnancy program makes those women feel like they belong and can get prenatal care the way they want to. So I do think there's an opportunity to incentivize that. And then to measure, are people going where you think they should be going, or are they going where they want to go? And how do we support those places in providing care to diverse populations?
You can come to New Mexico anytime you want. I'd love to have you here.
So longitudinal healing relationships, I hope I displayed, they have therapeutic effect. And at the heart of that is trust. Because trust is necessary for patients to believe the treatment you're recommending is something they should do, or that the person you're sending them to is worthy of their trust also. That they can reveal to you about past experiences and with sexual abuse or with physical abuse, or the things that are leading to poor health outcomes, or at least poor health choices later. Until they tell you about those, you don't know how to address them. So trust is really at the heart of those. And I said earlier in my slides, our effort is to try and align the measures that we're using in care to align the intrinsic, what I feel is right for this patient, with the extrinsic, what I'm paid to do, or what my system tells me I should be doing. And when those are in conflict, burnout is a product of that. Because now you're leveraging my professionalism. I'm going to do what's right for this person, even though it's going to be counted against me over here. So there's real importance not only in doing the things that build trust for the patient, but that support the capacity to be trustworthy for the clinician.
I just want to call out the point of starting from a conversation with individuals and families or communities about what's important, what matters, and then designing around that rather than designing around an outcome that doesn't matter, right? And so I think what my colleagues have said, have given examples of, is really starting from that listening mode, that honoring that perspective. And in our quality programs, I think we don't do enough of that. Design the program so that it attends to the needs of the individuals who are being served, but also offers the care team a way to serve them in a way where it feels like a mutually rewarding relationship.
I want to thank each of our experts so much for a really rich discussion. We covered so much ground and learned so much from your expertise. So thank you so much for your time. At this time, we're going to take a break until 1:10 p.m. Eastern Time. then please join us. We will have a great lineup of guests for our final listening session on addressing challenges regarding data, benchmarking, and risk adjustment. We'll see you then.
Produced by the U.S. Department of Health and Human Services.